The weapon of choice of the enemy there was the IED, the improvised device, or the vehicle-borne device. So a lot of it was explosive. There was some small arms fire, but very few and far between. So all of them were blast injuries. And most of the injuries are survivable because we had body armor. And with the body armor and the type of vehicles we had that would direct the blast away from the cockpit, I mean, that was later in the war, you had a lot of arm and, unfortunately, facial injuries. There was one area I was deployed to, and it was called a FAST. It was just a sort of stabilization point. There they had an orthopedist, a general surgeon, probably an internist, and whoever was left over. And I was the leftover guy. So at this particular area, we did stabilization. For example, a bunch of helos would come in, we'd stabilize. So I was doing extremity injuries. I was doing all the neck explorations, doing all the facial stabilization, stop bleeding, and move them on to the theater hospital. At that time was Balad in Iraq and Bagram in Afghanistan. So it was mainly stabilization at the smaller echelon hospitals, you call them that. Call them Army caches and EMEDs on the Air Force side. What was remarkable is that we all knew each other. I knew the Odo crowd immediately because it's a small world. If you look at otolaryngology, it's not that big an entity anyway. But in terms of who was trained at, the only thing I had to get under my belt, who was trained at the military facilities. I already knew all the civilian facilities who trained Army or Air or even Navy counterparts. So we would do stabilization at those. But once you got to the bigger theater hospital, Balad or Bagram, that's where you repaired folks. Now, our folks, you're talking about the golden hour, it was almost the golden minute. We'd take care of folks right away. We'd have them on a C-17 and back to Germany probably in about 24 hours. Just unbelievable. I mean, our capabilities, and not that you want to have these wars to practice them, you could see it just spin up. If you survived getting from the battlefield to at least the second echelon theater hospital, you were going to survive. That's without extremities. One time I remember I was at it was Al-Assad, which is in the news right now, and we had a gentleman who was going to lose both extremities. We literally just took a polypropylene tube, put it across, spanned both arteries, the femoral artery, and just got the patient stabilized, put him on a helo, transfused about 3-4 units of blood in transit, 45-minute trip, clutch a colloid, but that's what we saw. Of course, my expertise was head and neck, and anything from the neck up I was taking care of. That included neurosurgery. We didn't have a lot of neurosurgeons in theater. So the neurosurgeons would give us a course. It was called Neurosurgery for Dummies. Literally, it had the same type of Cliff Note type of background. But essentially, if someone could be trusted to make a intracranial exploration, it was ENT because of our background. So what we did, we decompressed the skulls so that patients wouldn't herniate. So we did a lot of those. We learned how to float sensing devices and everything else so that we could at least know what the intracranial pressures were. So that was something that we were able to do for our men and women in the military. Then finally, once I got to, when I was able to deploy to one other aspect, our guys went to Germany. Those guys had to stay there. Now, these were the Iraqi or the Afghani troops, and even the bad guys you took care of. So those folks, it ended up, we needed to do definitive care. Now, if they were still on the vent, there weren't a lot of vents for these guys, and whatever they did at Sadr City or, al-Baghdadi or wherever these places were that they'd have to go to, who knows. I remember about a 15, 16-year-old had his jaw shot off with it was, you can actually tell the type of armament. It was with a AK. And We put him back together, ventilated, shipped him off to Solder City, ends up coming back to our facility because we just couldn't house everyone. No one had even took the gauze off, his trach. No one even took the gauze or helped him with his trach. He was decompensating because of respiratory distress because no one cleaned his trach out. So we found a way to keep him in our hospital. So we saw all types of things, and I think having been a part of the trauma world before going over was my respite because I was able to deal with it. A lot of the young guys and gals who had to deal with this didn't have medical backgrounds.